It is up to the doctor now to control access to health care for all and to assess situation of disability. More recently, at the end of the 20th century, the proposals of Lord Anthony Giddens, who advocates the idea of a third way to modernize the post-World War II welfare state, have gained ground throughout Europe and beyond. This school of thought advocated that concept of an active welfare state. The aim was to establish a new balance between so-called passive policies of compensation and withdrawal from the labor market and activation policies based in particular on training and aimed at encouraging people to be active so as to prevent social protection from becoming an employment trap. For the doctor, it is now a question of assessing remaining capacities to be mobilized in order to envisage reintegration into the labor market. This new approach to reintegration has revealed the need for collaboration with other disciplines. A multidisciplinary approach has been developed. Doctors, nurses, physiotherapists and occupational therapists, psychologists, other paramedics and social workers are increasingly working with the beneficiary on his or her social professional reintegration. Indeed, at the dawn of the 21st century, a widespread emancipation movement has emerged, which in the social security system seeks to give to the citizen the first place in the care of health and work. This is also reflected in the demands for participation in the debate from patient associations and other citizens' movements. Doctors, accustomed to one-on-one discussion, have to adapt to these new expectations by working in a more collegial and transparent way. The recent COVID-19 pandemic has also had important implications for social security. New ways of working have generated new pathologies and required a new approach to assessment. Particularly the emergence of new communication technologies has changed the way consultation is conducted. Finally, the increase in the number of people unable to work and the exponential evolution of medical techniques and treatments, combined with a growing shortage of medical staff, has stimulated the development of computer systems based on algorithms and artificial intelligence. These developments present social security medicine with new challenges to ensure a human-friendly approach and transparent decisions. The growing shortage and aging of insurance and social security doctors will also need to be addressed if these new challenges are to be met with confidence. Better knowledge and recognition by society of their essential role in social protection system is essential to ensure that all citizens have access to fair, independent, personalized assessments and decisions. To conclude this historical evolution, it should be noted that although in the past the insurance and social security doctor was an informed observer and expert assessor of medical facts, he remained, or even had to remain, outside the therapeutic relationship. Today, it is increasingly clear that his action, particularly but not only in the policy of social reintegration, influences the therapeutic pathway of the social insured. The overall health of the population can no longer be conceived without taking into account the place of work and social integration in the well-being and dignity of the human being. If the insistence on the assessments of remaining capacities in the context of reintegration was already a major paradigm shift. The fact that the social security medicine has given a place in the therapeutic process is a Copernican revolution for social security medicine and for the medical world in general, the importance and the urgency of which has not yet been gauged, but with which it's not possible to develop here. Dr. Annette, our Secretary General, will come back to this point in her lecture. This is sufficient to prove that Eumass has more than ever a place and a role to play, both in terms of renewed collaboration with the medical world as a whole, and above all in terms of serving a society that is ever more open, equitable, fulfilled and concerned about the well-being of its population. In the following lectures, healthcare, capacity assessment and reintegration in today's setting and in a European perspective will be presented by our distinguished guest speakers, whom I thank very much for their contribution. But I must excuse Professor Loops, who is ill today and will not be able to give his lecture. And therefore I have to thank Dr. Lindenger, our Vice President and former President, who has readily agreed to replace him. He will give a lecture about development and comparison of workability assessment in Europe. I thank you very much for your attention and will now give the floor to one of the most distinguished guest speakers, Professor Dr. Vandenbroucke, who is Deputy Prime Minister and Minister of Social Affairs and Public Health, who is not here today, but he sent us a video because he has a Council of Ministers today as every Friday morning. So please, we will hear his welcome message.
Zeer geacht publiek, ik wil op de eerste plaats Eumass vandaag een hele gelukkige verjaardag toewensen. 50 jaar, ja, dat is een verjaardag met een gouden randje aan en daar mag uw vereniging terecht trots op zijn. Ik kan helaas niet live met u klinken op deze heugelijke gebeurtenis, maar ik ben blij dat de technologie het mogelijk maakt dat ik toch een bescheiden bijdrage kan leveren op dit feest. Ik trap een open deur in als ik zeg dat we bijzonder moeilijke tijden meemaken. Eerst was er een wereldwijde gezondheidscrisis die alle Europese landen, ook ons land, zwaar getroffen heeft. En nu zijn we in een oorlog terechtgekomen met zeer ernstige gevolgen in zaken energiezekerheid, energieprijzen, koopkracht en ons economisch bestel. En het belang van democratische welvaartsstaten is misschien vandaag groter dan ooit gebleken. En ik zeg uitdrukkelijk democratische welvaartsstaten, want dat is eigenlijk het enige goede antwoord. Solidariteit in onze welvaartsstaten en solidariteit tussen onze democratische welvaartsstaten op de agressie van Poetin in Oekraïne. Het enige goede antwoord ligt daar. En natuurlijk voelen we vandaag ook hoe belangrijk goed georganiseerde gezondheidszorg is en hoe belangrijk goed georganiseerde sociale zekerheid is. Die moeten er ook in deze energiecrisis staan als een dijk. En we weten ook dat zelfs met goed georganiseerde gezondheidszorg, zelfs met goed georganiseerde sociale zekerheid, de stress, de druk op mensen, de mentale druk op mensen in zulke crisissituaties natuurlijk groter wordt. En ik ga misschien één elementje nog toevoegen aan deze, ja, misschien wat sombere inleiding, maar toch een inleiding over de noodzaak om te behouden wat we hebben, sterke sociale zekerheid, sterke gezondheidszorg. Misschien één elementje dat het nog wat moeilijker maakt, dat is dat ook onze sociale verzekeringsgeneeskunde het vandaag wel erg moeilijk heeft. Ik zie dat in België al sinds een aantal jaren natuurlijk gebeuren, de steeds moeilijkere situatie waarin sociale verzekeringsgeneeskunde zit, maar ik denk dat dit toch ook in heel Europa wel een probleem vormt. Er is een tekort aan verzekeringsartsen en dat is zo op alle terreinen en in alle takken van de sociale zekerheid. Ik ga hier niet de analyse maken van de oorzaken van dit probleem, maar ik wil u wel heel kort aangeven hoe wij in België kijken naar de toekomst en vooral welk type van maatregelen wij nemen. Een steeds kleinere groep artsen met een steeds complexere job voor een steeds grotere groep mensen. Dat zijn eigenlijk minstens 3 terreinen: krimpende groep artsen, steeds complexere job, groeiende groep mensen waar je voor moet instaan. Het zijn minstens 3 terreinen waar nood is aan nieuw beleid. Dat proberen we in België ook effectief aan te pakken. En ik ga hier geen uitspraak doen over wat nu de topprioriteit is. Laat mij schetsen wat we doen. Bijvoorbeeld het voorkomen van beroepsgerelateerde gezondheidsproblemen, maar voor wie in problemen is gekomen, het stimuleren van snelle terug naar werktrajecten, om op die manier ook wel de caseload waarmee onze artsen geconfronteerd worden te verminderen, is een eerste heel belangrijke opdracht. Maar we gaan ook inzetten op het sneller en beter inschakelen van andere relevante disciplines, zoals ergotherapeuten of arbeidstherapeuten, psychologen, verpleegkundigen, in het werk dat artsen in dit domein moeten doen. Ook in de sociale verzekeringsgeneeskunde doet multidisciplinariteit zijn intrede. En dan gaat het mij dan zowel over artsen als over niet-artsen. En we initiëren ook projecten en platformen die ervoor zorgen dat de artsen gemakkelijker met elkaar kunnen communiceren, expertise kunnen delen en samenwerken met elkaar. Op die manier zullen we bijvoorbeeld heel praktisch vermijden dat onderzoeken dubbel gebeuren, omdat informatie niet doorstroomt. Maar we zorgen toch ook voor extra expertise voor het aanpakken van meer complexe problemen waar we vandaag mee geconfronteerd worden. Er is het Belgische TRIO-platform. Er zijn onze terug naar werkfiches met duidelijke guidelines voor huisartsen, die ontwikkeld worden door een werkgroep binnen het Nationale College voor Sociale Verzekeringsgeneeskunde. Er zijn pilootprojecten die we willen ontwikkelen voor samenwerking tussen huisartsen en eerste lijnspsychologen, die te maken krijgen beide met mensen die het moeilijk hebben in hun werk, die afgehaakt hebben, die arbeidsongeschikt verklaard zijn. En er is ook een project rond de functionele capaciteitenanalyse voor mensen met mentale gezondheidsproblemen. En er zijn andere acties die we aan het bundelen zijn in een Belgisch federaal beleids- en actieplan voor mentaal welzijn op het werk. En tot slot moeten we natuurlijk ook onderzoeken hoe we het statuut van de artsen die actief zijn in het domein van de sociale verzekeringsgeneeskunde kunnen verbeteren en hoe we deze belangrijke opdracht ook kunnen promoten, zodat ook jonge artsen positief voor deze discipline kiezen. En voor alle duidelijkheid, ik heb het dan niet alleen over de financiële aspecten van dit werk, maar ook over de opleiding, de erkenning en de mogelijkheden om samen te werken. Het is geen gemakkelijke oefening, we weten het. We rekenen daarvoor ook op gespecialiseerd wetenschappelijk advies om ons de juiste weg te tonen. Dus ja, we staan voor heel belangrijke uitdagingen. Maar laat het heel duidelijk zijn, we willen en we gaan er ook effectief iets aan doen. Het verzamelen van goede praktijken is een opdracht voor Eumass. En ik roep u dan ook graag op om ter gelegenheid van uw 50ste verjaardag mij en mijn medewerkers misschien ook te trakteren op een grote taart van good practices die we kunnen meenemen in ons beleid. Waarvoor bij voorbaat zeer hartelijk dank.
So you hear our Minister of Social Affairs is asking us, he gave us a mission, so we as the executive decided that we could take up this call from Minister Vandenbroucke, and we will not only thank him for his brilliant speech, but also go in on his invitation. So we will in the future surely come back with what kind of answer we send to Minister Vandenbroucke. Now, just going on what he said, I will ask Dr. Annette de Wind, who is our Secretary General, to give her presentation about medical assessments in Social Security in Europe. Annette, you have the floor and also the microphone.
Thank you, Mr. President. Thank you, Mr. President. Welcome, ladies and gentlemen. As it is stated on the Eumass website, about 500 million people in Europe are affected by social insurance schemes, funded or endorsed through society as a collective social security. Decisions on entitlement and benefit are usually based on medical assessments, which in turn are based on European insurance medical knowledge and common methods. However, insurance medicine does not exist in Europe as such. The assessments are often carried out in their own national way, without European coordination or consensus. During European meetings and congresses, in which scientific developments and practical experiences in the domain of insurance medicine are exchanged, we noticed that although medical assessments are carried out in the context of social security in all European countries, insurance medicine has only in a few countries developed into a medical specialty. There is a lack of clarity about medical assessments in social security in Europe and about the education and training of doctors working in this field, while the outcome of such assessments has far-reaching consequences for both individuals and society. It was therefore important to gain insight into the situation that has arisen in the field of insurance medicine. Since the aim of Eumass is to provide a platform to exchange experiences within the field of insurance medicine between various insurance-related organizations in Europe, mainly focusing on public social security, I have spent the last years, with the help of Eumass, council members, researching the necessary knowledge, skills and competencies for those medical assessments in insurance medicine in Europe. How did the current social security situation in the different European countries come about? And what does it mean for daily practice of medical assessments in the social security context? Who are the doctors who carry out such assessments? What tasks do they perform? And how are they educated and trained? Questions that arouse our interest, but to which we initially found no answers because European research within social security has generally compared the systems with each other and in particular emphasized the differences between those systems. Hardly any consideration was given to the role of the doctors within these systems and to their required education and training. Therefore, our research goal was to develop a European core set of tasks as well as of education and training in order to harmonize as much as possible both insurance medical practice and the required education and training. Several studies were carried out with the help of Eumass, for which I'm grateful. They have given us the necessary insights into the insurance medical work in European social security, on the basis of which we have been able to make various European comparisons and it has enabled us to develop a European core set of tasks, knowledge, and competencies required to execute those tasks. A number of comments and considerations can be made on the basis of the results. Within the social security systems, physicians are mainly deployed for the assessments of absenteeism and disability or incapacity for work. This puts them and the associated insurance medicine in a special position, because unlike other physicians, they seem not to fulfill the role of healthcare provider, but rather of loss adjuster, who checks possible health damage against the policy conditions of a public or private disability insurance. As a result, insurance medicine is not regarded as curative medicine and is therefore generally not taught as such within the undergraduate curriculum, which is dominated by disease and curation. With the exception of only a few countries, this also applies to the postgraduate training, in which insurance medical topics are taught fragmentarily, usually concerning the claim assessment schemes, and then often from a historical and national perspective, which has created major differences in education and training situation of physicians working in the insurance medical field in Europe. Besides this apparent failure to fulfill the role of a healthcare provider has consequences for the position of the physicians working in social security and the associated insurance medicine. In fact, a work disability assessment should be part of the treatment that, after all, also aims to restore functioning at work, and all the more so because work is often involved in the onset and course of the disease. Unfortunately, however, in practice, such an explicit work-oriented treatment objective is often not the case. Conversely, an insurance physician will have to form an opinion about the remaining chances of recovery, whether or not with the aid and efficient intervention. So there should be, or is indeed, a link between curative and insurance medicine. But this link also seems to be missing in quality development. All kinds of efforts are made within medicine to bring the medical practice in line with the state of scientific knowledge and to keep it up to date. The development and implementation of guidelines, the introduction of new interventions, instruments, and procedures and training should contribute to this. However, these efforts are usually only curative, whereas the scope of medicine ought to be broader as physical, mental, and social system levels are intertwined. Attention to the consequences of the disease for the functioning of the individual in his or her social context, including the patient's work situation, is for the most part limited, though. Because developments in medical knowledge regarding etiology, diagnostics, prognosis, and treatment usually do not include insurance medical elements, they often bypass the insurance medical domain. On the other hand, improving the quality of work disability assessments generally focuses only on the interpretation of disability legislation and on the implementation procedures, rather than on the quality of the assessments as such, which in insurance medicine is not just about the medical assessment of the patient, as in the curative sector, but about a broad assessment of the claimant in his or her psychosocial context and the use of efficient interventions. Insurance medicine thus operates within the legal framework at the intersection of healthcare, society, and economy. An insurance medical advisor or decision also unites various interests, primarily those of the individual, the claimant, but also those of the collective, the insurance company and society. The latter is to guarantee the affordability of social insurances and provisions. Social security systems, like healthcare systems, are usually funded by a system of premiums and taxes. Both systems are under pressure, not only from rising expenditure, but also from economic and social changes. For example, disorders are becoming more chronic. Multimorbidity is increasing, and socio-cultural developments are leading to patients/claimants becoming more assertive and generally getting older, which means that they will have to work longer, whereby lifestyle becomes more important too. As a consequence, the emphasis is more on maintaining functioning and self-reliance than on healing. As a result, not only the demand for healthcare, but also for social medical services is increasing, while there is a shortage of healthcare personnel in general and physicians working in social security in particular. It was what the minister said as well. Hence, not only expenditure is jeopardizing affordability, both individual and collective, and thus also accessibility and quality of the services, but the shortage of physicians has negative consequences for quality, accessibility, and affordability as well. So following the curative sector, task transfer is increasingly being introduced within social security. However, here too, due to the lack of a clear insurance medical identity, we see that this introduction takes place differently within Europe. In view of the just mentioned considerations, insurance medicine occupies a special position on all sides. Given this special position, one would then actually expect it to be an independent medical specialty. After all, a medical specialty is generally defined as a subfield of medicine that requires specific expertise for which specification and enhancement of competencies acquired in the graduate program are required for deepening of that specific subfield. The additional education and training must be described in a competency-based manner in accordance with the European standards in medical training set by the European Union of Medical Specialists, Eumass. And there must be a training structure with the associated safeguarding mechanisms. This means that the training, besides the general competencies of the specialist has to include further developed specific competencies. In addition, continuous medical education must be provided. Then there are also requirements for the training institutions, and the guarantees for an optimal training climate must be laid down. Furthermore, specialty must have its own scientific domain. Given the huge differences in the current training situation, ranging from no additional training or education at all to a 4 to 5 years postgraduate training and education program, it is not realistic to introduce and require a 4-year insurance medical training in all European countries at the moment. An initial European basic education and training program in insurance medicine, though, based on the core competencies, knowledge and skills on which there is consensus, could be a first step towards harmonization of training. This modular education and training program can then be gradually developed into a full insurance medical curriculum over time. There still seems to be a long way to go, but hopefully Eumass is going to have a long and bright future in which it can play a role in the introduction and implementation in the various countries, sometimes against the historical and national customs. Not intending to supersede the competence of the national authorities with regard to postgraduate training, but rather to complement, if necessary, and harmonize the content of national education and training programs, so that insurance medicine eventually becomes a European recognized medical specialty. Long live insurance medicine, and long live Eumass.
Thank you very much, Annette. If we have some time left at the end of this morning, we can ask questions, but I suggest now that we give the floor to our colleague, Dr. Gert Lindenger, Vice President of Eumass, who accepted to replace Professor Lux and give us a presentation. I will give him the floor now. Thank you once again.
Thank you very much. So let's see if we can get the right slides up there. Ladies and gentlemen, dear audience, I'm very pleased, despite short notice, to be able to give this presentation, and it's on my favorite topic, so I'm especially pleased with that. And it's concerning development and comparison of workability assessments in Europe and some more, and that is a bit about Eumass' contribution during the years. And I would like to start up with this picture here, and what kind of work do you do? Work? That's the question. We have a number of challenges in the future, and actually we already see the trends. And the first one is service and digital economy have changed physical work requirements. Aging populations stay healthier, live longer, and may perhaps also work longer. How do we take care of that in the best way? But the third one, which I would like to pay most attention to, is the psychiatric problems. Mental non-well-being seems to be in a steadily increase. There are two major perspectives concerning insurance, and one is the legal, of course, and then there is the medical, and in between is insurance medicine. Workability assessments for medical reasons have much in common between different countries. However, the outcome of a claim may differ because of different national legislation. It's always interesting to compare different countries. This is statistic from Eurostat Labour Force Survey, and it is for the last 30 years. It's only 8 countries, but nevertheless I think it's rather interesting. The dotted line is the average percentage of sick leave, slightly above 2%. Then we can see during the years that we have 3 countries that have been sort of exceptionally high. And we have the Netherlands 20 years ago, and then we have Sweden just after, and then also Norway still being high. Why these countries are interesting to look at is because they have had the problem and they have been trying to do something about it. We also notice that UK and Denmark are the lowest. Denmark is especially interesting because there is no social insurance there. It's only the social welfare that takes care of this part as well. So, what diagnosis constitutes a problem? Here is a diagram of Sweden in 2014, and then 42% were sick listed because of psychiatric reasons, and 20% of musculoskeletal. If we look in 2020, we now have the statistics divided in women and men. So 49% of women are sick listed because of psychiatric reasons, and 38% of the men. Obvious and well-defined diseases are seldom a problem. Obscure conditions substitute a problem, especially if mixed with mental discomfort and pain. So this is a challenge we need to address. So how can we measure? In 2001, WHO decided to publish the new ICF, International Classification of Functioning, Disability and Health. And ICF provides a terminology for describing health consequences, but it can be used in different ways. So if we look at disability, it's useful for sick listing. And if we look at functioning, it's useful to describe residual work capacity. Here we have an interesting slide that shows how one can connect WHO's 2 terminologies, ICD-10 for diagnosis with the ICF, and actually the first slide I saw this was done by Freddie Fallet, who's sitting over there. Thank you. And if we look at a specific diagnosis, we can try to see if we can describe the body functions, actually to make it simplified, the impairments at organ level, what arm or what mental capacity is not really functioning. And then, of course, we have to describe the activity limitation at an individual level, meaning what kind of task cannot be performed because of this condition. And if we then compare it with job tasks, we can see that we should theoretically find out some kind of work incapacity. Sometimes there are other limitations, but if it's not connected to work, they're probably not insured. If you think the former slide was difficult, here we have the easy one. So if we got it diagnosed with illumination error, the function level would be eventually broken lamp bulb, could be a broken fuse as well, and the resultance will be inactivity limitation, darkness. However, this is connecting to a more biomedical view. If we go to ICF, many of you are acquainted with this picture, and if we put the diagnosis, the function impairments and the activity limitations here. These constitutes the biomedical. But now, if you can see, there are still a lot of things to describe, and these are what we would need to describe if we would include the biopsychosocial model. So we have the environmental factors being connected to the social side, we have personal factors, and we have work, which is a way of participation. But there is one small dilemma. ICF never coded the personal factors. I know there have been attempts in Germany to try to code these, but it's still a very interesting field that needs to be developed. Here we have a slide that is from UK. It is from Gordon Waddell and Kim Burton's report, and they try to phrase it like this: the biopsychosocial model, where biological refers to the physical and mental health condition, psychological recognize the personal psychological factors also influencing function, and the individual must take some measurement of personal responsibility for his or her behavior. And the personal cooperation is of essence, of course, in all kind of rehabilitation, and we also need to look into how the claimant is in his or her compliance. So I know that, for instance, in the Netherlands there is a protocol where one tries to assess this, but that's about the only one I've seen internationally, maybe more though. Social recognizes the importance of the social context, pressures and constraints on behavior and functioning. This slide was very neatly summarized by Sir Mans Leilwood in this sentence: how people think and feel about their health problems determine how they deal with them and their impact. And this really says it all. So, what do we need and what can we use apart from ICF in order to look into personal factors? And there is other scales, and one suggestion from NIHDI psychiatrist Christopher Bass was that one should look into the brief illness perception questionnaire. And another one is about the injustice experience. Pain catastrophic could also be of interest. Patient's health questionnaire, which is referring to the number of symptoms experienced by the claimant. And then we also have short form 36 describing health situation and hospital anxiety and depression scale. If we look at the brief illness perception questionnaire, which is actually a psychological questionnaire with about 500 questions, it's been cooked down to a very short brief list by Elizabeth Broadbent from New Zealand. And there are two questions which are specifically interesting and correlates directly to the length of sick leave. How much control do you have over your illness is the first one. It's actually on the slide, the third one. And the other, how much do you think your treatment and help will can help your illness? Of course, if you don't believe really by heart in school medicine and you are more into alternative medicine, the experience that traditional doctors could help you would not be very successful, and that might turn out to be one of the major hindrances. Then, of course, we also have time. Motivation to return to work seems to decline as time passes. And one in UK, they pointed out that the first half years are usually very crucial in order to try to get the person on sick leave to return to work. And if you pass over that time, there is an increased mental reorientation towards non-participation. Actually, in the beginning, after 3 weeks, 92% believes themselves that they will be on only a temporary sick leave. So we have to be aware of time. So what has Eumass been doing in order to make good use of ICF in assessments? In 2004 to 2006 there was a working group that decided to put together and see if one can achieve a core set for permanent incapacity. And that is, a core set is a short list of what is in ICF. ICF is a thick catalogue that only makes you sleepy when you read it. But what should always be in an assessment? And there was suggestions from all the Eumass different countries, and we received 172 different activity and disabilities items that were thought to be relevant. And after a long and tedious voting procedure led by Vandenbroucke in Norway, we managed to agree on 20 items. And what I would like to point out is that this is the first international agreement of what to look in an assessment ever. So what happened with this list? Well, in France it was used in their way, in the Utile aide à la mise en invalidité. I hope I pronounced that fairly well. If you can see the list is rather well the same things, but in Estonia one tried to look at the higher chapter, the 7 domains that were in this list, and we can find locomotion, dexterity of the hand, communication, self-care, learning and applying knowledge, adaptation of changes, interpersonal actions, but in the middle, which is driving everything, is energy and driving functions. And that is quite correct. And what we're done with this in Sweden, here we see the first Swedish assessing list, and we can see that it's mainly the same as Eumass core set. The black one are concerning physical appropriate situations, and the yellow are mental activities, the green are mixed. In 2011 there was another development in Sweden where one tried to use the original activity limitations of the core sets and group them into larger areas. So then we had 8 different groups: physical strengths and mobility, 7 activities limitation, physical endurance, vision, hearing and speech, balance, coordinating and fine motor skills, features of memory, learning and concentration, executive functions, affective functions and mental stamina. So what does an assessment look like? This is the Swedish example. But of course, please remember that the clear and very straightforward diagnosis, they never even appear in an assessment because it's obvious how to deal with them. But say that after 6 months, perhaps, we have 10% still on sick leave and we don't know why. These are the ones that are sent for an assessment like this. So what do? One checks the medical background, and then the claimant is asked to fill in a form where you describe what kind of symptoms and what kind of problems they have. The form is brought to an interview with an assessing physician, and one makes a clarifying interview and asks especially the claimant to describe situation where his or her condition is a hindrance in reality. And then a physical examination is done. First you look at what is supposedly the problem, and that is describing that the glass might be half empty. Then you do another survey which is standardized of the medical condition, and then you might find out that the glass is half full after all. So some things may be working. if there was any mental diagnosis, or if the claimant is describing any mental problems, a check-up with the International MINI, which is a short list for checking the psychiatric diagnosis, is done. And then you may also, as assessing physician, if you don't think that what you have found is an adequate description, you may ask for paramedics, like for physical or mental testing. I will get back to that. The result is described in a form in Sweden where you can compare with the job demands of the 60 most common works, the largest works in Sweden, and they are described with the American ONET system, occupational net system, which is a profile. So these two fits together, you put it in an Excel file, and you find out and give a pretty good guidance. Of course, the final decision is always up to the decision maker. If one should go for optional special physical exam, that means that we have a physiotherapist and an occupational therapist that do several tests in order to check, for instance, mobility or endurance. And then one common complaint now is cognitive impairment, meaning I think I don't have any good memory left, I can't concentrate. And if you have that, you need to do some kind of neuropsychological testing. But the aim of the testing is not to give a full neuropsychiatric diagnosis. It is just to find out if the cognitive impairments are enough severe to impair any kind of work. And this is, I think, one of the most interesting parts. If we compare to Australia, they have the same arrangement. So, as you can see, psychological assessment on the left side and physical assessment on the right side. I would also like to highlight the American initiative from National Institute of Health, which is ordered from the US Social Security Administration. They don't have much of insurance that is public in the US. They have a lot of private though, but they have definitely a large number of persons asking for claims, and about 3 million claims needs to be assessed in the US. So they wanted to have a system where the person in his or her situation could be describing in a very simple way in a computerized system, and this is the FAB, Functional Ability Battery. And what's interesting is that it is, if you compare on the left side, which is the ICF illustration, they include personal factors. These are the different areas where the FAB is doing. Actually, FAB is a computerized system where the claimant only fills in on a question, yes or no, yes or no. That's everything. And the first question, the answer of that will decide which question will arrive in the next order. And it will usually, there is about 330 questions, and each claimant will not fill in all them. They will have an intelligent system. Item response theory is the background to that will choose the next question. But the point is that we will get a description from the person, the claimant, his or her description, which of course is essential to recognize as well. And we can also, when using this system, be able to see if the claimant is giving consistency in the responses, because different questions measuring the same thing will pop up again. And if anyone just tries to deceive the system, we will find out that there is a lot of variation, too large variation between the different questions. Now, the National Institute of Health has now a collaboration with Eumass, which is possible through the EU Commission, SRSS department, where we have several countries in Europe, Belgium, that have been now translating this, and also in Germany, and we are now also trying to do that in Sweden. And hopefully, for instance, in a general practice, this simple test that takes about 20 to 30 minutes could be useful in order to find out after, say, 3 months sick leave, which are the cases one needs to send for further assessment. So there are several uses of this. So, to add up, the obvious and well-defined diseases are seldom a problem. Obscure conditions substitute a problem, especially if mixed with mental discomfort and pain. These can only be understood through the full biopsychosocial model. Most people with regular disease can work to some extent, but the central issue, how much discomfort is it reasonable to let society ask from individuals in order to demand that they should support themselves? Thank you very much for your attention.
Thank you, Gert. So I will give now the floor to Dr. Saskia Decuman. She is from Belgium. She is from the National Institute for Health and Social Insurance. And she is also at the coordination of the Knowledge Center. One of the interesting points is that the National Institute in Belgium has taken some years ago the decision to create a Knowledge Center. And that Knowledge Center is what also Eumass is aimed to have research on sick leave, on working capacity. And that's the reason why we asked Saskia to give a presentation how research in Belgium has come to some interesting findings and conclusions. So Saskia, thank you once more for giving your presentation.
Thank you very much for the invitation. I will, after presenting a short word on the Department of Research, Development and Quality of our disability benefits, I will make a focus on the disability management training that we are organizing in Belgium and our Center of Knowledge. I am very lucky to present you also today the people who are working currently in my departments and who are together with me responsible for the disability management training and the certification, as we have since 2017 a license with the NIHDI Institute of Canada to organize the training and do the certification. And we are together also responsible for the daily scientific coordination of the Center of Knowledge, of which Dr. Berkijn is the president. You have heard the ministry, there are a lot of challenges also for Belgium. So with our department, we are of course also having some responsibilities in responding to questions coming from the Minister of Social Affairs and Health. And of course, we also try to support and communicate with other directions of our department. So like I told you, it is for the 7th year that we will organize in 23 the disability management training. Here you see the evolution in the number of inscriptions in that training. We see in year 5, in 21, a huge increase in the number of people participating in that training, because that was the year that we had the development of the multidisciplinary teams within the social insurance companies, in which it was decided that all non-medical people working together with the medical advisor are now obliged to follow the disability management training. And in 2022 we had a new initiative with the start with the certified return to work coordinators within the social insurance company, which make that these people working together with the medical advisors. They are obliged to have succeed the exam, so this makes that also they want to follow, of course, the educational training. Not everybody, of course, decides to follow, to do the certification, so that means that at the end of the training, people can decide to fulfill an exam. 50% of people who follow the training also do the exam, and we see a success rate of 70%. This is totally in line with the success rate we see in other European countries. This doesn't necessarily mean that all those people also have a valid certificate, because people have to prove every year and a half that they stay active in the field. So to give you more concrete figures, in Belgium now we have 100 of Belgians, more or less, who have a valid certificate since the beginning of the disability management training. That means that 1 in 4 people who start the training have succeeded the exam and also have a valid certificate. For us, organizing the training is very challenging, because in the beginning, when our former head of our department asked me to organize the training, it was in the idea to do it 2 or 3 years, and then it would be okay. But we saw that the training was very successful, and now the implementation of the certification in a royal degree, we foresee that it will be a long-term process for our institute to continue in organizing the training. Which is for us very challenging, as people who are following the training are a very heterogeneous group. On the level of education, we have doctors following the training, but of course also psychologists working in the private sector, psychologists working in social insurance companies, same for occupational therapists. So it's very a challenging task to be able to offer the training also for people with very different levels of experience. And as, of course, the people of the social insurance companies are one of the priorities in our training, to keep it also for them as challenging as possible, as of course for most of those people it's also an obligation to follow our training. So this is a very different point of start for people who voluntarily follow the training. To share also some results of our Center of Knowledge. So when I started working for the INAMI in 2014, we launched the Center of Knowledge, and it was a one-person responsibility. And now I'm lucky to have 5 people working with me in that department. And since the start of the Center of Knowledge, we have now finished 22 studies. 2 studies who are in the last phase, 10 studies in the phase of data collection, and 1 study in the phase of development of the protocol and asking approval for budget. For us it's very important to set some priorities for the future, so that means more communication on results and more focus on implementation. It's really for me very important that we cannot say in the end we have 15 studies done and they are in our library of the receive. No, it's very important and a first priority to really have results who can be implemented and who really can offer tools to make things better in daily practice for the medical advisors and their teams. That means that we also have to develop more formalization of our procedures and our tools. We launched our Center of Knowledge in 2014, and now we have came up to the idea that we have now a lot of experience with our studies, so it's also very important to try to work in a more efficient way with formalization of tools like protocols, what we want for researchers, how they have to implement a demand for budget, etc. I didn't want to give today just an overview of results of some studies, but I want to focus today on some challenges we see with some of the studies who have been launched, who are now in the phase of data collection or who have been finished. And I make a distinction between of those studies who have a focus on the level of assessment and evaluation and studies on the level of intervention. One of the first studies, or one of the first initiatives the last years who caused, I must say, a little bit of headache for a lot of people, is the questionnaire of the Quickscan, which started with the past Ministry of Social Affairs, who asked the Center of Knowledge, I want you to develop a questionnaire who can be used for a prediction of long-term work incapacity, and who could also support the patient filling in that questionnaire, because by filling in his questionnaire he would be able to think about his problems, his work incapacity and his return to work. After doing an intensive literature review and a validation study, we developed a questionnaire who could be sent to the insured person in the 8th week of his work incapacity. But I have to say that this also, on the moment we did that study, and also now in the implementation phase, because the minister you heard this morning decided to further formalize the use of this questionnaire and have put it in a royal decree, so it's now really implemented in daily practice and people are obliged to fill in the questionnaire. And this was challenging because what started with scientific research who encounters a lot of difficulties is now formalized as procedure. And why was it challenging? Because the scientific research was done in a period in a negative context. It was in a period with implementation of new legislation in Belgium, in which there was a lot of negative communication about will sanctions be applied. So we cannot be sure that it has not have an implication on result and possible biases. We also have challenging on the level of the content of the questionnaire, because it was developed more in the perspective to be used for people who still are active, who still were active in the labor force and not for employed people. As we see now, it is sent to everybody. So it needs adaptations in the future. And also I must say that we have to say that it will be an obligation, so there is a new legislation who will be published soon, in which patients are obligated to fill in the questionnaire, so that could also have, of course, an implication on the results. We also had, you already heard a little bit about the FAP today. This is also for us taking a very important place in our current research agenda of the Center of Knowledge. This is a study coordinated in my department by Theo Benoit, who is also present today. And we are now ready with part 1 and part 2 of the FAP. That means we received financial support of the European Commission to translate the FAP into Dutch and into French, and to do the first endeavors in the validation study. And now in November or December, we will ask the advice of the Center of Knowledge and the approval of our board to have next financing to really validate the FAP into the Belgian social security context. So it will be very challenging for us, because for us the FAP is a very important tool who could support the work in the future of the medical advisor. Because as you have heard, it's a very fast, intelligent system to have knowledge about the activity level of the insured patient. But it's very challenging because we will need the medical advisors in that validation procedure. And as they are very, very charged in the work they have to do every day, we think it will be very challenging to have enough patient inclusions to really be able to do this scientific part of the validation. Because we need, for instance, to give you an idea, 3,000 patients who participate in the validation study to be able to reform, for example, also the scoring which was developed in America, but which also has to be adapted, of course, to the Belgian context. So this is also for us very challenging if we really want to do research who has an importance after that research to be implemented in the daily practice of our social insurance companies. we need a good collaboration with them. And this is of course very hard, as their daily tasks asks already very much of their time. Another study, which is also important of course, is a study on the functional capacity evaluation done by the occupational therapist. This is a study which has received approval for budget, so we will start with a pilot by the end of 2002 and beginning 2003, where we will test the return on investment of doing a functional capacity evaluation by an occupational therapist working in rehabilitation centers or working from regional employment services on the decision process of the medical advisor. So the medical advisor who wants a functional capacity evaluation will have the opportunity to ask one to be done in the private sector, and the occupational therapist will have to fill in a template. And we will ask at the end of the study if the results of the functional capacity evaluation translated into the template had an important consequence or had a good result for the medical advisor to take into account into his decision on worker capacity and reintegration. This template we have developed together with the medical advisors and the occupational therapist is based on the ICF. So also the ICF context core set, who was developed by Eumass, was used to develop the template. And it was important to develop a template because occupational therapists sometimes work with different tools, and so we could avoid discussions and we could avoid that we had to force occupational therapists to work with one tool. So that means that they can work with whatever the tool they want, but the only thing they have to do is do a full, they have to fill in the template, and the template will be standardized for everybody who is included in the study. But also here I would like to highlight that it is also challenging for the medical advisors to take part into this kind of study. We have taken as much as possible measures to foresee that they will just have to send people to the occupational therapist and afterwards report to us if the functional capacity evaluation was very a support for them. But it still means that when they do consultation, that they have to explain briefly the study to the patient, that they have to ask for informed consent to study patients. So it is still challenging, we think, in daily practice to take part in such kind of studies. Like already mentioned by our Ministry of Social Affairs, we have a study running on functional capacity evaluation in common mental health disorders. The first priority in this study, which is now having a kind of preliminary phase before we will launch a public protocol on it. The first priority here is to support the medical doctors working for our department. So we will launch a study in which we will ask a multidisciplinary research group in selecting tools who can be used by our medical doctors. And in the second phase, we will do the analysis if those tools could also be a support in other contexts for the medical advisors or for other medical doctors working in other departments of our social security sector. My department was also involved in the implementation of case management within social insurance companies. So here you see a picture with our minister taken on a workshop he organized between the return to work coordinators, who are now formalized, implemented in the social insurance companies since the 1st January of 22, in which for which a routing is foreseen in legislation. So that means that patients on working capacity can be referred by the medical advisor to a return to work coordinator, or can also spontaneously ask to their social insurance company to be seen by a return to work coordinator. An initiative also with a lot of challenges, because we see a limited number of people who will be able to take up this role. The Ministry of Social Affairs has foreseen 14 return-to-work coordinators for the whole federal state of Belgium, 61 in 2003, so 20 extra, and if I remember well, 10 who will be specifically specialized for people who are working as in an independent way. So this is not enough, of course, because these people can have a very a big range of tasks, and it will also be the responsibility, of course, of the social insurance companies to see how they will implement this new of working, how they will devise the task between the medical advisors, the non-medical doctors working in the multidisciplinary teams, and the certified return-to-work coordinators. Another study which is now running for several years in our department through an RCT is the study on individual placement and support, where the medical advisor can decide when he encounters somebody with a psychiatric disorder in which he sees or foresees that there will no spontaneous resumption to work, that he can send this insured person to an IPS coach who is working for the regional employment services. IPS, the most important principle of this methodology, is based on the place and then train principle, in which we try to put somebody as soon as possible back in the labor market, and that everything who has to be done on the level of training is done when the people are really already working. And that the support for the IPS coach is not only there for the people, only for the patient, but also for the employer. This is a very expensive study, because this is a study running for, I think, already 7 years, because we really wanted a long-term follow-up of these patients going back to work under the responsibility of an IPS coach. And we also wanted to be sure that the return to work was something we could see on the long term. So we also recently had the approbation to prolong this study until 2025, and this will give us the opportunity to have a long-term follow-up of 30 months, so almost 3 years, for the whole group of patients. Because we see now, we have now for the patients who are included until now, we have now the results for the 1 year and a half follow-up, with very good results, with a very good return to work. But for us it's also important to see if people really go back to work, to qualitative jobs, and if they really stay at work. Because we must say that the investment who has to be done in this kind of projects, if we see how much work it costs to get those people back to work, we have to be sure on the return on investment. Because we see a lot of endeavors in this patients group with psychiatric disorders, a lot of problems on the return to work, also in our system of the progressive return to work, a lot of problems with that legislation and how it can be implemented, and the problems it gives in the daily field for the IPS coaches to guide the people to go back to work. We see also that it is a patient group with a lot of challenges in their private life, so it's a real investment to really strictly follow the IPS methodology. So we have to be sure, if people go back to work, that it is really in good jobs and that they really stay at work. We are now preparing, it's maybe a little bit contradictory. At the one hand, we are waiting for the definitive result, but parallel with that, we are already preparing step by step the implementation of the ICF model, because it will take a long road, because we have to implement it through the agreements we have between the federal state and the regional employment services. So for the moment we part a little bit of the idea that IPS will be a stayer, and we try to prepare implementation, so in the long run, when the government decided to really implement IPS, that we don't have to wait, so that we can implement it directly after the study. Another project we also have running on our department is on the principle of nudging. The principle of nudging, I suppose you already know what is the principle behind it. It means that you try to sensitize people to change their behavior. And in our sector, we try to test the principle of nudging to give information on partial work resumption when we send the letter on entrance in work disability. So when people are more than 1 year on sick leave, they receive a letter of our department to acknowledge that, and we added for half of them getting that letter information on partial work resumption, because we want to test if the group who receives the information on partial work resumption will take more the initiative to really resume work. This is a study which is still running. The first results show a significant difference, a significant increase in people who apply for progressive return to work. But also we have to be careful when we interpret that results of that study, because of course giving people information on partial work resumption and that they take their phone to ask their social insurance company or to ask their employer or to ask, for example, their job coach, I want to resume work, doesn't necessarily mean that formal steps will be taken. There are a lot of people involved who have to give their permission. For example, the employer, if people do not have the possibility to go back to work in a formal job, it could be the case that they immediately quit of taking steps to resume work. So those results, interpreting those results is also, of course, we have to be very careful. And of course, we took here the most easiest way to reach people, and that was adding information on our letter. But we may not forget that people are already 1 year on work incapacity. So in an ideal situation, people get this information much sooner. But for us it was the most efficient way and the most fastest way to be able to send this nudge to people on work incapacity. Also, a very important priority for my department is the link between the healthcare sector and work incapacity and return to work. So we financed several pilot projects in the multidisciplinary pain centers. The multidisciplinary pain centers in Belgium are under the same responsibility, of course, of our own Ministry of Health. But that doesn't mean that we automatically have a lot of initiatives on return to work in these centers. We see that it is almost a hazard that there is attention to the problem of work incapacity and reintegration. And in this moment there is no formal obligation in the conventions between the Belgian government and the pain centers to do a lot about social professional reintegration. We did the analysis and there is one sentence in the convention saying you have to take action on social professional reintegration. But in their yearly report that they have to submit, for example, to the Belgian government, they are not obliged to really report on what action they have really taken. So that means that it all depends on an active medical doctor who really will put the attention on this program on return to work. It depends on having health professionals who say, okay, I found it important to take it into account, but there is no formal obligation. So this is why we have launched this pilot project to see what kind of initiatives those multidisciplinary pain centers had set up who are active in that field and who do it with their own financial possibilities. And there we saw important topics as the role of the general practitioner in chronic pain. They also tried to develop questionnaires on prediction of long-term work incapacity. There was a pain center working with case management, and this is why we decided to try, as we have the same minister who is responsible for social security, work incapacity, and those pain centers to look what can we do to formalize the problem of work incapacity in that conventions. And it's a very sensitive topic in Belgium because everything which about multidisciplinary pain centers are financed based on biomedical interventions. So if they have a lot of biomedical interventions, financing will follow. But for example, if they prove that they have a certified return to work coordinator in their center, they will not necessarily have more financial incomes. For example, there is no financing for functional capacity evaluation. If they ask an occupational therapist to do a functional capacity evaluation, that means that less hours are at the disposal for having really giving therapy to people. So one of the first decisions we have taken is to try to start very small and to try to convince to add an annex to the convention. What this means that we will explain what we understand under social professional reintegration. As I told you in the beginning, in their convention it is mentioned that they have to do actions on social and professional reintegration, but there it ends. So we will try to implement, or we try to add an annex to the convention, which has to be signed by the multidisciplinary center, by explaining what is social professional reintegration. What can you do about it? What is case management? How can you progressively reintegrate people by explaining what the legislation is in Belgium? Because the knowledge is sometimes knowledge is very absent in that multidisciplinary pain center because they don't work with occupational therapists or physiotherapists or psychological therapists who have followed training on that problem, so they are not having the necessary knowledge to really be able to put the attention in care also on work incapacity and reintegration. So I hope with these examples of research which is currently running in our department, but I have given you some information about the challenging we are having every day together with all the partners who try to make this research a success. Thank you very much.
Thank you very much, Saskia. You put very interesting information and see how research done by your national institute is also combining with the work done in the field by the medical advisor. So it's a very interesting lecture here. The last one, but not the least, I will give the floor to Professor Oostra, will give us an example how to rehabilitate, and in this particular example it is done about patients after stroke. So thank you very much for giving your lecture.
Thank you for the invitation. So I would like to go into the vocational rehabilitation of patients post-stroke, more particularly the fourth phase of a regular rehabilitation post-stroke, which is the vocational rehabilitation. As you can see in the ICF, we are at the level of participation. This is an important part of the post-stroke rehabilitation because we have seen that 20% of stroke patients are below the age of 65 years old, so within the working population, and this number is increasing over the last 20 years, so with 25%. Moreover, we see that we see more patients with mild stroke thanks to the new therapies that are available, which are thrombolysis and thrombectomy, and because of that we see a lot more patients with partial hemiplegia or partial cognitive problems when I started my career 30 years ago, all those patients had a full-blown hemiplegia, so they were not able to follow the vocational rehabilitation, but now this is the case. So return to work is priority number one within the guidelines or several guidelines of rehabilitation. It's an important rehabilitation goal for the patient. It gives financial and social advantages, and it promotes the global well-being of persons. So about 50% of stroke patients are within the mild stroke patients. So that means that they score on the NIH stroke scale between 0 and 5. Those people have completely different needs than people with a full-blown stroke. So they are being told that they have a very good recovery. So when they go home, they think that they will be able to return to work, that they will be able to drive, that they will be able to resume their meaningful life role. But then they encounter difficulties. It is not going the way they expected it to go. And why is this the case? Because there is an underestimation of the symptoms these people still have. Their screening tools we use are not sensitive to capture the problems they still encounter. And due to that, we don't give those patients effective interventions. When people with mild stroke are in acute care, they are just dismissed and no rehabilitation is being offered. So they come home, they expect full recovery, and then they encounter difficulties. Because community reintegration will be difficult because of concentration problems, because of memory problems, some motor impairment even, but especially because of the slowing of information processing and the fatigue that those people do feel. And that's why we need to introduce neuropsychological screening in these patients. We have to apply standardized neuropsychological testing to have a good insight in their cognitive status when they go home. This will promote their self-knowledge. They will have a better insight in their own capacities. It will show the rehabilitation needs, and it will give a prognosis for return to work. And in this Dutch study by this author, this researcher, it was shown that only 60% of neurologists in the Netherlands offer neuropsychological screening to patients with a mild stroke. So there is some work to do. Research has shown that in a very acute phase, the first 2 weeks after stroke, the Montreal cognitive assessment and the clock drawing test, a very simple test, would be very giving a good prognosis for return to work. So those are rather simple tests, but they give a good prognosis for the ability to go to work again. In the subacute phase, we will do more broad screening of attention, reaction speed, memory, and visual spatial functions, and especially executive functions, because those are necessary for return to work. I'm going to give you a quick look into our neuropsychological test battery. In our department, we use 3 kinds of test batteries. This first one is the global basic neuropsychological screening we do. So first we screen for attention using these tests, and especially TODA and TOSA are tests that are interesting for people that will return to work. This is an example of a simple Bourdon-Wisma. So people are just asked to find all the four dots, and then we can see in what time it takes and if they miss 4 dots. The TOSA, for example, is a test of sustained selective attention, and in this test, it's a very simple test. You hear groups of 2, 3, and 4 beeps, and you only have to press the button when you hear 3 beeps. It's not difficult, but the difficulty is that this test will take 10 minutes. And you have to sustain your attention for 10 minutes to hear the 3 beeps. So this is a test which is an important test when we screen people for return to work. Now we go to the memory tests, verbal memory, visual memory. This is an example, you all know, the complex figure test. People are asked to give, to draw this picture, and then they have to repeat it from their memory. I don't know, I always ask myself, would I succeed? Well, I don't think I'm so visual. This, at the other hand, I think I would manage, is the auditory verbal learning test. So 15 words are being produced by the researcher, and then this is repeated 5 times, and people have to reproduce those 15 words, and then after 40 minutes they are asked again to reproduce the 15 words, and there is also a recognition task. And then finally we have the executive functions. This is the highest level of functioning, cognitive functioning, and there is a problem with this executive function test because we have the impression that they really don't capture daily life problems that people encounter when they have problems with these executive functions. This is an example of the Wisconsin card sorting test. So people have to or follow the color, or follow the form, or follow the number. And each time they get a mismatch, they have to change. So for example, here they get a mismatch because they were following the form and they have to follow the color. So it's a test of flexibility as well. And this is another example of the pads, an executive test. You have to try to remove the cork without touching the material. You can only touch the small can, the lid, and the metal. I'll give you time to think. So this is the first and basic neuropsychological screening test. Then the second battery, also very important, is the test battery for the driving ability. In Belgium there is a law that says that after stroke, even mild stroke, one cannot drive the first 6 months. So even when you return home without any physical problem or without any obvious cognitive problem, you cannot drive the first 6 months, which is quite frustrating for patients. But we have this test battery, a computer test battery that tests people for divided attention, flexibility, visual field, neglect, things that are important for driving. An example for this divided attention, people have to push the button when they see 4 squares, 4 crosses that form a square, and at the same time have to push the button when they hear the same tone at a certain time. So they have to divide the attention between the visual and the auditive cue. This is an example of a neglect test within this driving battery, and here you can see an example of a patient with a severe left neglect. So at the right side you can see the time it took the patient to see the spot, and on the left side you can see that he did not notice any spot. So he has a severe neglect and he is certainly not able to drive. So this neuropsychological screening showed the presence and severity of cognitive impairment, but there are some questions about the ecological validity of those tests. Do they predict functioning in real-life situations? Yes, if they have the same demands as in real-life situations and jobs. So we have some other tests, observational tests, that are also very important to see how people are functioning in daily living.
And like any test, this neuropsychological screening is also a problem for underachievers, but I don't think you can avoid that. If people are working in a very difficult and high demanding administration, we do use this third test battery, a Center for Basic Interactive Research, computer tests, which are also used in recruitment and selection procedures. So these tests do an evaluation of labor skills, but at a higher level. It's going to look into social skills, reasoning, administrative skills, planning and organizing, and others. So 3 test batteries, so we know how people are functioning cognitively. And then we are going to look into the vocational rehabilitation. Let's first have a look at the definition. What do we mean when we say return to work? Do we mean part-time or full-time paid work? Or do we agree that working some hours a week is also return to work? Some authors use minimum 50% of the former work schedule, or others use the definition of no sickness compensation. So we have to agree what we mean by returning to work. What are the predictive factors? Well, it seems that people that are self-employed return more often to work than employees. That people with higher education return to work more often than people with a lower education, which seems a bit contradictory, because we think, or many authors think, that cognitive problems are the main issue for people with mild stroke, and one would expect that higher demanding cognitive tasks would lead to lesser return to work. But maybe some physical problems, although minor, could be difficult for people with physical jobs to return to work. And there is also the problem of safety, because if there is some minor physical problem, there is very often a problem with the employers that don't want to give people post-stroke a job with some security issues. So that are possible reasons. And as the colleague from Sweden already said, the positive attitude and support from others is very important when returning to work. And even the nation, because Denmark and the Netherlands, for example, are having a very high score in return to work, and Belgium is somewhere in the middle. Men are returning to work as often as women, and as I already said, white-collar jobs are returning to work easier than blue-collar. Then there are some factors that are related to the severity of the stroke. People with a hemorrhagic stroke are usually having more severe handicaps, and people with aphasia, we sometimes try to get into work, but it's very difficult because language is maybe the basis of returning to work. And there is also the time, because in this study by Drong, it was seen that after 6 months about 40% of people are back to work, and 2 years he found that 66% of patients have returned to work. So we have to give patients some time. I want to go into this post-stroke fatigue, because post-stroke fatigue is one of the major complaints of people with mild stroke. About 40% even considers fatigue as the most important complaint. And what is fatigue? Fatigue is an energy loss. It's a feeling of weariness. It's a loss of motivation. And people always say that rest doesn't help them to recover. And they have problems with initiating and keeping up activities. This post-stroke fatigue is a very big problem, and I'm doing this work for 30 years, And the strange thing is that the first 10 years I never heard the word fatigue. People never mentioned that they were tired. But the last 15 years, this has become the main complaint. And my opinion is that probably our society has something to do with it, because we are all overwhelmed with stimuli. I was sitting in the train this morning and I was looking around, and I was the only one who was doing nothing. Other people were looking at the computer, on their phones, and we always do two tasks. We are always multitasking. So I think that is possibly one of the reasons why this complaint of fatigue has become so important, because these people have a slowing of their information processing. So when a lot of stimuli are coming to them, they are feeling overwhelmed and they are feeling tired. And I think that even in other sickness, this is an important issue. Our society is so demanding. So we can use the fatigue severity scale to score fatigue, and a Dutch colleague has developed a detection list for fatigue, which is a list that detects all determinants of fatigue, so it allows the treating physicians to address certain problems, such as sleeping problems. So it's the most important complaint in 40% of people, and the most important reason of work delay. Even when you look at all kinds of influencing factors, fatigue seems to be the most important reason why people with mild stroke don't return to work. And it's more obvious in people with mild stroke and in younger patients, probably because younger patients are more active and are expecting to do more, and in this way they feel this fatigue. There is some link between post-stroke depression and fatigue, but it's not the same, because there are also a lot of people that suffer from fatigue that don't have a depression, that don't score positive on a depression scale. What is the treatment? We are going to use cognitive behavioral therapy to learn people how to deal with their fatigue. We are going to use graded activity. It seems to be very important that these people stay active and do a lot of physical activity. We also promote power naps. Only that. And then finally there is some medication. Most of the studies that address fatigue are done with modafinil. I don't know if you're familiar with that medication, which is used in narcolepsy, but it's the only medication that has been really investigated for post-stroke fatigue. I have no experience with this modafinil, which is a dopamine reuptake inhibitor, but I use regularly in younger patients methylphenidate, Rilatine in our country, and I have very good results with this medication in a low dose, and I think it's always worth trying this medication. So vocational rehabilitation is the bridge between care and work, and as other colleagues already mentioned, it is very important to introduce work very early in the rehabilitation trajectory. We just have to mention it. You might be able to go back to work from the beginning. It's very important. And now, it's going well out. There is this project, We Go to Work. It's supported by the European Social Fund, and it's a project where work professionals are integrated in the hospitals, so we can send our patients to those work professionals, and they can have a first advisory consultation without any pressure, and it's really working very, very good. So I think after the project this will be a nice step that those people, those work professionals will be introduced into the hospitals. And then we do the assessment as the start of the vocational rehabilitation. We try to have a good view on physical skills using functional capacity evaluation, cognitive skills using our neuropsychological tests, and also the emotional and behavioral skills, because that's also an important issue in acquired brain injury. So when we go to the different kinds of vocational rehabilitation, we are using the combo. We do the program-based vocational rehabilitation, train and place. So first, there is an intensive rehabilitation of labor skills, and then we go into job trials. Work professionals usually use the supported employment model, place and train. So people are being placed at the job, at the workplace, and then are being supported by an on-the-job coaching. It is very important in rehabilitation that we introduce as soon as possible real work conditions. We have to try to practice and evaluate labor skills, promote insight and limitations, and create realistic expectations. We are working in the university hospital, which is a very big hospital. I think we have 6,000 employees, and we have very different jobs. So what do? We are going to introduce our patients in the hospital to work with the technicians, to work in the garden, to work with the nurses, to work with the teachers. And in this way, we try to mimic real work conditions and have a good evaluation of the labor skills of the patients. And then we go into the job trial in the real environment. We are calling this continuing rehabilitation at the workplace, so people stay on a sick leave and sick leave compensation, but we have created a kind of insurance so they can go to the workplace and work as a kind of rehabilitation on the work floor. I have seen in literature that in Sweden some kind of this same system exists with job trials of 3 months that is also paid by the social insurance. And it's a bit the same system that we are using. To avoid the negative attitude of the employer, he doesn't have to pay the patient, so it's more patience with the patient. And the patient will not develop feelings of inferiority and not feel the pressure of having to because when he's paid there is always this pressure. So this is a system that really works. We have a lot of administration. We have to, of course, ask the doctors of the insurance company, of the social security for their approval. Then we are going to analyze the tasks, anticipate problems, and then educate the employer and the colleagues. And it also asks for an intensive follow-up. So we see patients every 3-4 weeks. We contact the employer every 3-4 weeks to see if we have to adjust what we are doing. And we work very progressively. We always start with 2 or 3 half days and then try to build up until paid employment. Finally, I want to mention that there's also the return to work from a patient with a stroke is also a challenge for the employer and the colleagues. It's an emotional challenge because they have a colleague, they get a colleague back that's not the same person as the one that left. And there is a practical challenge because they get more responsibility. We often ask for feedback and we feel that people are very reluctant to give feedback because they feel a bit awkward that they are involved in this evaluation of their colleague. And they also say, we don't know anything about stroke, what can we expect? So that's why disability managers, why people, job coaches are important. And that there is a need for a long follow-up. Even coming coming here, I was checking my mails, so I was not doing nothing on the train. And checking my mails, I had a mail from a patient who went to work, I think about 2 years ago. And she now sent us a mail, I am fired. I have to look for another job. So I was very happy that she found us, that we were still in her mind. We can get help from the rehabilitation center. What are the results? So when we go and have a look at 2019, we included some more than 100 patients in our ambulatory program. Most of those people suffered from stroke, and the other big group are people with traumatic brain injury. When we look at the stroke population, you see it's a rather young population, 49 years old, and about 1/3 of those persons were already on pension or on sick leave. But you see, this is not only a mild stroke population, because a lot of those people had a hemiparesis in more or less. These are the results. So those patients, those 30% were already on sick leave or pension. The 31% did not return to work, and the other 30% went to work, are partially, are full-time, are in a non-paid volunteering. So I think it's a nice result, because about 50% of the patients that were still working went back to work. And I want to give, as a last slide, I want a comparison with traumatic brain injury, which is a younger population, and you can see that in this population, only 70% did not go to work, that about 28% resumed work full-time, and 25% part-time, 16% returned to school, and 11% went to volunteering. So you can see that there is a difference between the post-stroke and post-TBI population. Thank you for your attention.
Thank you very much for this very interesting and very in the field experience. So we have some minutes left for questions to our distinguished guest speakers before my concluding remarks. So are there any questions for our speakers? Who will? Yes, François.
My question is for Saskia. I was really interested by your research that you have investigated, and you have shown that you have about 20 studies in which are kind of tools to implement to improve the uptake and to improve the return to work process. And well, it's a lot of tools in a domain, but in a field where we have not so many. So my question is are these tools published, or are we in free access? What's the pathway to get there?
The studies are available. Normally they should be on the website of our department, but I have a little bit of lack in putting them available. But we can maybe send to the people of Eumass all the final reports who are available in Dutch and in French. So we do not publish until so far in English.
Another question?
Thank you. I would also address the same field. You said that not all the persons that are trained take the exam at the end. What is the difference? Is there any difference in their legal status or regarding their jobs?
So first of all, it's very important that those people who work as return to work coordinator in the social insurance companies, they have to succeed the exam 2 years after they started in the function. So this is a group we expect who will participate in the exam. The feedback we get from students who do not participate is that they don't want to have the idea that they may not succeed. So sometimes they have to follow the framework of from their employer, sometimes they do it voluntary, but normally the students who follow the training voluntary are already for years working in the field, and they don't want the risk that they would not be certified and that they would miss to succeed the exam. It's a pity because they have two possibilities, so they can participate 2 times. It's 1 day of an exam, multiple choice. It's very hard. We are not used to that kind of exam in Belgium because we have to follow the strict regulation we adopted from Canada. So we have 300 questions and 10% of questions can be adapted to the Belgian contexts. So we have 270 questions who everybody in the world gets when he does that kind of exam. So people are a little bit afraid not be able to succeed. They say, what if I do not succeed? What will my employer say? So we can think that that will be the reason. And some people say, I don't have to prove anymore. I am good in my job. I follow the training, but I will not do the exam.
And then they lose money.
No, there is no recognition of the certification in Belgium. So you can have an employer who wants you to have the certification, but the certification is not recognized. So if you see patients and you have the certificate, you cannot be reimbursed or something like that. You really have to have another profession. No, it doesn't have consequences for me.
Yes. Oh.
President, can I just first of all say that I was very impressed by the presentations today. And there are just a couple of comments I would like to make and then a question. My first comment is that I was president 25 years ago, and so my information processing capacity is probably not as great as it was. There has been a lot of information. The comment I'd like to make is that there's this wish that we become more associated with the therapeutic side of medicine. But the problem is that we are seen as being obstructive to people getting benefit. Now, I don't know how that applies to all European countries, but I know from my time in Eumass in the past that this is a very real problem. I retired a year ago, but time and again, and I still remember it so well, people coming before me as a tribunal judge in the end, saying, you're just there to block me getting benefit. And there is a public perception and a professional perception that has to be overcome by doctors in our specialty, that we are there to help people. And we think that we get this message across, but actually, I think that even today, years after I was involved in this work, that is still a problem that we're not getting across. The final question I'd like to put to our final speaker is the subject of fatigue. And I think fatigue has become very fashionable. Have we any means of researching what we mean by fatigue so that we can separate the leaden fatigue that is pathological from the emotional fatigue that people like to talk about? Thank you.
I think that there is a lot of literature about fatigue, but there is still few results about the cause of fatigue, and that one of the first trying to disentangle fatigue is this detection list that was made by the Dutch colleague, which tries to divide fatigue into different components. And this makes it more treatable, I think, and also more acceptable. But one of the I think that when 40% of people feel that it's the most important complaint, we cannot just say that this is a feeling we should not deal with. And that's the difficulty, because when people go to their social security doctor or insurance doctor, as you say, fatigue is a problem that is hardly listened to sometimes, and also not being, it's hard to be objective. So that's the difficulty.
Thank you, but I was looking more at actual cerebral function. Are there MRI scan changes we can use?
Of course, there are always changes on the scan. Even when people are depressed, we also see changes on the scan, so it's difficult. But there is one study with this modafinil, the vigilant medication, and those investigators looked into the difference in the functional MRI before and after modafinil. And they saw a difference in functional activity in the frontostriatal thalamic pathway. So that's one of some investigations that were done so far.
Perhaps one last question. Yes, Lisa.
Good morning and thank you very much. I'm Shahad Adash from the Standing Committee of European Doctors, CPME, and together with my colleagues we're very pleased to be invited to this special occasion. Very proud that Eumass is one of our associated organizations. I've been learning a lot, and just very topically, yesterday we were at a meeting with the European Commission and they were asking what we are doing on long COVID. And I was wondering, I think probably from your sector that there is a lot of experience here, and I was just wondering in what format this was being addressed in terms of workload, in terms of different ways of working, new therapies. I'd be very interested.
Annette, perhaps we discussed it yesterday morning, just.
Yes, but Sarada, can you please say exactly what they were asking for concerning long COVID?
What we were doing on long COVID, and if we had discussions at CPME on long COVID, and so far we've had very little discussions. So I was wondering what Eumass is doing on those.
Yes, we have discussed it actually yesterday at a joint meeting of the Executive Board and our Scientific Committee. We want to carry out preferably a survey among the members of Eumass in the coming time to see how long COVID is dealt with in the various countries. And of course, at our upcoming Congress, which will take place end of September next year in Strasbourg, COVID and long COVID will be a topic that will specifically be attended, both in plenary sessions, but likely also in a workshop or parallel sessions combined, and where we would like, if possible, to also present the outcome of the survey. But I'm also looking towards Corina, our chair of the Scientific Committee, if I phrased it correctly.
Yes, we will discuss. The first time when we discussed this issue was yesterday, but we will surely discuss this in the next meetings of the Scientific Committee.
So it has our attention, but we realize that it will be a challenge, especially as the first people calling in sick with COVID, there was no testing whatsoever. So we were talking about fatigue before. Fatigue is now linked to COVID, but it was linked to other diseases as well, which were not too well defined. And so it'll be a challenge to assess it in an appropriate way.
Yes, a last remark of comments.
It's just a feedback. I know that the ISA work group, so the International Social Security Association work group on rehabilitation, also does an assessment on long COVID through the members of. So I think it could be good to see if that the questionnaire which is there used cannot serve the Eumass. So I bring you into contact with Nathalie de Wolf, who is the secretary of that working group.
Thank you. That's of interest, but of course ISA is more, I'd say, the administrative side of the social security organizations, and we discussed yesterday that we would also really like to look at it from an insurance medical perspective, but it can always be useful to look at that questionnaire and take it into account.
For sure there will be place enough to discuss during lunch and aperitif, so if there are some questions you would ask, don't hesitate to do that during the coming minutes. And at the end of this interesting and exciting morning, I would like to thank the speakers once again for their contribution, of course. I'm sure that their brilliant presentation will stimulate discussions during lunch. But before we move on onto an aperitif, I have a more pleasant duty to perform. On the occasion of this 50th anniversary, I must, on behalf of all of you, thank those without whom today's celebration could not have taken place, and even more so, without those whom Eumass would not exist today. And so I would like to mention in the first place Miss Lies van Meerbeek. Who for many years has been the dedicated secretariat of our association. The COVID pandemic did not allow us to pay public tribute to her when she left. May this be rectified today. So please come forward, Lies. I was told only one rose because we have a long day today, and if we have to go with many, many flowers, it will be a bit difficult. So I give you a little present from FNAC. I love literature, so you can choose what you want and not too heavy to take home at this time. So please. And as you see, I have some more roses. That means that today Oriana, who stays there in the back of this room, has taken up the torch. This is also an opportunity to thank you and to encourage you to continue the path traced by Lies. So please come forward. Yes, and then how can we not thank our Secretary General, Dr. Annette de Wind, whose efficiency and dedication are no more to demonstrate. Her perseverance has enabled Eumass to reach the level of quality we know today. So please, Annette. Roses left, and the next one is for I forgot to mention Dr. Jean-Pierre Broncas, of course, our tireless treasurer. He spared no effort to make this session a success. He has spent days and even nights in order to achieve, sometime in extremis, what we are presenting to you today. And one of his ideas was to offer a memory book. That book is ready, but we have had problems with the designer, problems with impression, and so we will have, and it grabs an opportunity, as we have a very good photographer with us today, to have not only a memory book about the 50 past years of Eumass, but also from this day, this celebration day. So we will integrate what we saw today, what we experienced today in that book, so every one of you will receive that book on PDF, but also in paper. So Jean-Pierre, thank you very much for all what you did. And finally, I would also like to express our gratitude to the Royal Academy of Medicine of Belgium and its permanent secretary, Professor Georges Casimir, and also particularly to Mr. Alexandre Bichet, who is present here, who welcomes us today in this very symbolic place. And as already Annette told this morning, although insurance medicine is still seeking recognition as a specialty at European level, at least the doors of the Palace of the Academies of Belgium have opened for us today. So Mr. Bichet, thank you very much for your the first time in 55 years he received flowers. So, you see there are no more flowers, so there is more than one reason to raise our glasses and toast to Eumass. We have no glasses here, it's not permitted to come with glasses in this room. So I will ask you and invite you to go to the splendid marble room. We have a very marble hall even, and we'll there have aperitif and have lunch together. There are tables, so you can sit down for having lunch, but also walking for having aperitif, and afterwards we will have coffee. So many occasions to discuss, to celebrate, and once more thank you, all of you, to join us today, and hoping we will see you on other occasions here in Belgium, or perhaps in Strasbourg, when we go to the European Parliament for our next Congress. So thank you very much. Enjoy aperitif and lunch, and yes, long live Eumass.